Hello, I'm going to be talking about AFib today. So, what AFib is a type of arrhythmia. It occurs when the atria beat irregularly and out of sync with the ventricles. So, typically, we have the cardiac signaling going from the atria, traveling through the node, and then going all the way here, and then going up. We have a nice contraction. But in AFib, we've got signals all over the place, so it is much messier. So, we've got an irregular heartbeat. And this can be seen right here as well. Nice QRS, and then for AFib, all over the place. So some background, some risk factors we have are advanced age, high blood pressure, obesity, diabetes, heart failure, ischemic heart disease, hyperthyroidism, CKD, moderate to heavy alcohol use, and smoking. We've got complications that can arise from this, so heart attack or stroke, hospitalization, heart failure, blood clots, and death. And then some symptoms. We've got palpitations, tachycardia, fatigue, weakness, dizziness, lightheadedness, reduced exercise capacity, increased urination, mild dyspnea, and then more severe symptoms would include dyspnea at rest, angina, presyncope or rarely syncope, symptoms of stroke or other systemic embolic event, and then symptoms of heart failure. And then when I did my topic discussion on this, my preceptor wanted me to go over the guidelines because they have changed recently. So how they've changed the previous classification system was based on arrhythmia duration and focused primarily on therapeutic interventions. The new classification identifies AFib as a disease continuum that requires a variety of strategies at different stages, from prevention to lifestyle and risk factor modification, screening, and therapy. This new classification system parallels the idea of disease continuum in other guidelines, with the goal to prevent progression of AFib. So now, like before, it was paroxysmal, persistent, blah, blah, blah. But now it's more so at risk, pre-AFib, AFib, or permanent. So we can like move up and down rather than being in here. And then now we've got slightly different rhythm control recommendations. So before it was just heart rhythm control with a resting less than 80 is a reasonable strategy. But now we kind of have it slightly different. So with people with reduced function and a persistent AFib, a trial of rhythm control should be recommended to evaluate whether AFib is contributing to the reduced left ventricular function. So not just for everyone, you kind of have to see if it's being caused from that or some other cause. And then catheter ablation. In the old guidelines, it was kind of recommended for anyone, but these days it's more so recommended for people that are younger or with fewer comorbidities. With symptomatic AFib, a useful first-line therapy. And then for acute treatment, we can use this little flow sheet. We can treat them inpatient or outpatient depending. So if they are hemodynamically stable, then we're going to see if they have decompensated heart failure because that's going to guide our treatment options. If they do have decompensated heart failure, we have amiodarone, or we've got our different CCBs, so rapamycin or diltiazem, which these are not the best options. You can see like the guidelines are 2B recommendation, so I don't really like those very much. And 3 is harm, so not the best option. So decompensated heart failure, oof. But then if they don't have it, we've got these ones, so the beta blockers, and then verapamil diltiazem, that's the first line. And then we can consider digoxin or amiodarone. And then if they are unstable, we would like to do a direct current cardioversion right away just to get that heart back into rhythm as quickly as possible. And then you can also consider cardioversion for stable patients later on as more of a long-term solution. And then we also need to consider anticoag considerations for long-term care. And then the things we could consider when thinking about if we're going to do anticoag or not, we're going to use the CHADS VASC score. So things that go into that are if they have heart failure, hypertension, if they're older than 75, if they've got diabetes, if they've had a prior event like a stroke, TIA, and then if they have vascular disease, if they had a prior MI, PAD, or aortic plaque, and then if they are slightly older but not in this age category, they get 1 point, and then females get 1 point. Lucky us. And then it is a maximum score of 5. So if it's a male, score of 0 means they don't really need anticoag, but then if it's a score of 1, it's recommended. And then for females, a score of 1 is no anticoag, or 2 plus, it recommends it. But then we also have to consider their bleed risk. So we have to look at that has bled. So if they've got hypertension, that's uncontrolled, they get a point. If they've got abnormal renal or liver, 1 or 2 points depending. And then stroke, bleeding tendencies, labile INRs, if we're talking about warfarin, then elderly, and then if they are on drugs or alcohol. So then we have to weigh these things. So if they've got a score of 3 or greater, it indicates caution. So we'd want to compare and contrast their bleed risk or anticoag risk and see whether or not they should be on one of these medications or if the bleed risk is too high. And then the medications we use for this are warfarin, typically with a goal INR of 2 to 3. Dose is very dependent on patients, so it can be anywhere from like 1 milligram up to like 12 milligrams. So it really depends. Then we've got our DOACs, we've got Eliquis, 5 milligrams twice a day, or 2.5 if they've got 2 of the following. If they are older than 80, if their serum creatinine is over 1.5, and then if they are less than 60 kilograms. We've also got Xarelto 20 mg QD, and then Pradaxa 150 mg the PAD. And then for maintenance treatment, the goals of treatment would be to prevent recurrence of AFib and then prevent stroke and systemic embolization. So we've got rate control, we've got our beta blockers, which slow conduction through the AV node. Digoxin may be useful in patients with limited tolerability to other agents, or as adjunct therapy in patients with a difficult to control ventricular rhythm. And then we're going to look at their ventricular ejection fraction as well when considering which ones they should be on. If they have a low ejection fraction, we do not want to use the CCBs because it has shown to cause harm. So we don't want that. And then another reason we might use digoxin is if their AFib is still happening, but their heart rate's getting low. This one is not going to affect heart rate as much as the beta blockers. So then we could use a combination of digoxin and metoprolol, let's say. And then non-pharm things to worry about with AFib. We want to be managing different disease states like obesity, alcohol consumption, hypertension, smoking, diabetes, as well as doing physical activity. The recommendation is 210 minutes per week, and then limiting alcohol, so 1 or less drink per week, ideally. And then we've also got rhythm control, so a different way to go about helping control AFib. So it uses either antiarrhythmic drug therapy, percutaneous catheter ablation, and or surgical procedure. Electrical cardioversion may be necessary to restore sinus rhythm. Antiarrhythmic medications are generally started before cardioversion and continued to maintain sinus rhythm. So for this, we're going to look at their ejection fraction. Once again, the most common one is amiodarone. That is by far the most common one I've seen, outpatient and inpatient. Technically, there's other options too, but that's the biggest one I've seen. Just amiodarone has quite a few side effects and drug interactions to worry about. Well, I mean, as well as digoxin. So those drugs you just have to monitor, counsel very well on. Thank you so much for listening. If there's any questions, please feel free to leave a comment. Thank you.